Thank you, Dr. Dhar, and thanks to the entire organizing team of Apollo Academic Session. Special thanks to Dr. Yadav, Dr. Dhar, and Dr. Agnivesh Tiku for taking an effort to teach a rare subject to young budding orthopedicians, and that is orthopedic oncology. With those words, I will take in next about 30 minutes to 35 minutes. I'm going to take you through a small journey where we will see how a suspected bone lesion, if you get in your clinic, how you going to evaluate it. And as I always start with the greetings from this great institute, Tata Memorial Center, which is one of the pioneer in musculoskeletal oncology, not just in subcontinent, but globally. So I'll speak about bone tumors, how you need to evaluate, and if time permits, we can discuss apart about management as well. So we know that bone tumors are very rare disease. They form about less than 2% of all malignancies. Their actual cause is not known, and hence most of these lesions are sporadic. But we definitely know that these tumors arise in growing skeleton, which is growing very fast, and hence we see in first few decades more. And obviously the areas which are growing, that is around the metaphysis. There have been some postulations regarding the genesis of these tumors, but these are just postulation and nothing has come true except for some very rare mutations where they come as a part of entire syndrome. When you are in your clinic as a general orthopedic surgeon, you will encounter a lot of benign and malignant bone tumors. So in just a couple of slides, I've enumerated the most common lesions which you will see. In benign tumors, you will see giant cell tumors, fibrous dysplasias, unicameral bone cysts, eosinophilic granulomas, osteochondromas, osteomas, and some non-ossifying fibromas. These are the most common lesions which you see. Among malignant lesions, the most common are osteogenic sarcoma of the bone, followed by Ewing sarcoma, and obviously some metastasis as well. Many people ask that why do we need a detailed evaluation when we are trying to look at a suspected tumor? Why cannot we group them all together? But as you are seeing this algorithm and as you go down the algorithm, it is pretty obvious to see that the function preserving surgeries form one part of the treatment and which is essentially done in a lot of benign tumors. But when we talk about malignant bone tumors, it is actually wide surgical resection is required. And in addition, you need help from a lot of other colleagues from medical oncology and radiotherapy. So what I'm trying to say is that the management of benign malignant bone tumors is completely different from malignant bone tumors. And if we try to treat them vice versa, we're going to end up in a lot of disaster. So if you get a suspected lesion, a lytic lesion, or a suspected tumor lesion in your clinic, you need to ensure whether you are dealing with tumor or there are very important probable differentials which include infections of the bone, metabolic bone disease, and few developmental disorders. When you have ruled them out and then you understand that this lesion looks like a neoplasm or a tumor, then you need to broadly differentiate them into malignant ones or the benign ones. All benign tumors are also not the same. There are of different varieties, and I will give some examples. Let's, for example, patient had some knee pain, you did an x-ray and you find an incidental non-ossifying fibroma, which has not given any complaint to the patient. Such lesions are latent lesions, which are not growing. There are some lesions which are growing very slowly, and those are called as active. And typical example is unicameral bone cyst. Many of times it is also detected incidentally after history of some pain or trauma in young adults. But on the other hand of the spectrum, you can have some really fast growing benign tumors, which appears like malignant tumors. And these are giant cell tumors of the bone, chondroblastomas, and aneurysmal bone cysts. So again, all benign tumors are not the similar way, and you need to really differentiate them into different varieties so that you can assign a correct treatment to each of these. When we talk about malignant bone tumor, we again need to differentiate them into whether this tumor is primarily arising from the bone. So, like for example, is it an osteosarcoma or a chondrosarcoma or Ewing sarcoma? And also need to differentiate it from the secondaries of the bone, which might have come to the skeleton from other primaries like thyroid cancer, rectal cancers, renal cancers, lung cancers. Again, why this differentiation is important? Because the management of this each spectrum or this is algorithm or each group is completely different from others. How you will treat a primary osteosarcoma of the bone will be completely different. How will you manage a metastasis from a breast tumor? And hence, this differentiation, this broad classification, this systematic approach is very, very important. So what are our aims of doing this evaluation? First, you need early detection. We all know we are dealing with neoplasm and we don't have much time. We need to diagnose them correctly and so that we can start our treatment in an appropriate way. Hence, we detect early. After detection, we start our treatment in the correct way. We stage the disease locally and systematically in a correct way to understand the extent and the spread of the disease and start the treatment in proper sequence or in proper way. So these are the aims of evaluating a suspected bony lesion. I always teach my students that diagnosis of a bone tumor is just not clinical or radiological or histopathological. Actually, it is a combination of all three. And the correct diagnosis is based or standing on these three pillars, which all together contribute equally to come to a correct diagnosis. And how we do it, let me show you. So, the first component, we talk about history and clinical examination. When you are taking a detailed history or evaluating a patient, we need to primarily look at three important things. First is age of the patient. Second, at which location this tumor is present in the bone. So whether it is in the epiphysis, metaphysis, or diaphysis. And third and very, very important point to note is the history. History essentially what I means is the progression of the disease. Whether it's a slow growing tumor, which shows a sort of benign pathology, or it's a very fast growing tumor, which shows aggressive pathology. So these are three very important things which you need to evaluate. Now, this is a simple table which is actually present in all the standard books. We also write the tumor part of TUREC as well. So this is present there also. And this table classifies various benign and malignant tumors which occur most probably in a certain age group. But what is very important to understand from these two slides, I'll just go to and fro, is that all primary bone tumors, whether they are benign or malignant, they essentially occur in early phase of life. As I said in my first slide, they occur in growing skeleton. Okay. And as we move forward towards above 40 years, we see that we get lots and lots of metastatic bone disease. And hence, this age of presentation is again very important. Other point is within the primary bone tumors, when we look at malignant bone tumors, osteosarcomas and Ewing sarcomas occur in first and second decade of life, while chondrosarcomas occur in an adult population or later. Similarly, giant cell tumors also occur in mature skeleton or the adults. So these are few salient points which will help you to differentiate. But mind you, there are always a lot of exceptions to these. Again, this picture will be available in a lot of books, but what I want to convey you from here is that there are some specific tumors which like some specific sites. Like for example, first on the top, you see round cell lesion, that is Ewing sarcoma, typically occurs in diaphysis. Then you see osteosarcoma typically occurs in metaphysis. You see chondroblastomas and giant cell tumors. They typically occur in apophysis and reaches subchondral bone. But this doesn't mean that you cannot have osteosarcoma in diaphysis. In TMH, we see about 20 to 25 diaphyseal osteosarcomas every year. It doesn't mean that you cannot have Ewing sarcoma in metaphysis. We see about 30 to 40 metaphyseal Ewing sarcomas every year. So these are most probable locations, but these lesions can happen in other sites as well. So this is to remember and to differentiate. As I spoke just a few minutes before, that in symptomatology, we need to take particular points into consideration. And the first one is the pain. We need to know what kind of pain it is. So the pain, is it because of the destruction of the bone, which will be like a deep, boring, dull, aching type of pain? Or it's a pain which is because of the compression of neural structures by growing tumor. So you should be able to differentiate that. Second and very important point is progression of the pain, which will be directly related to the progression of the disease. And as we all know that swelling is, again, because we are talking about neoplastic disease, obviously swelling will be one of the main prominent symptoms. So again, in swelling, we need to know how big is the swelling, where exactly it is located, how it is progressing, and how many swellings do you see. We also need to look at whether it is associated with any deformity, which is whether it is actually because of the neoplastic disorders or because of related to any other reason. Because tumors causes lysis to the bone, these bones become very weak, and if they are in lower limb, most of these patients may not be able to bear weight or walk, and they may present with pathological fractures as well. One of the very important points when you are assessing a malignant bone tumor is to also look at symptoms which tells you about the distant spread of the disease. Lungs are the most common site for distant spread of the disease, and hence, if you are suspecting, if you are suspecting a malignant bone tumor, you must look at symptoms related to the distant spread. And for lungs, it will be respiratory distress or any other bony pains if they have bony metastasis. In general, if patients are presenting in the last stage, they might have poor general health, which is also known as cancer cachexia. So once you have this symptomatology with you, you will go ahead and then evaluate your patient clinically. In this slide, I have enumerated the salient points which you must know or which you must evaluate your patient with. This is very helpful when you have a short case in the exam. So if you know all these points, it will be very, very easy to present your case as well. So you look at swelling. Okay, what is the size of the swelling? From where to which extent it is located? You should also talk about the exact location in terms of fixed bony points as well. Which are the compartments this swelling is involving, whether it is one compartment or multiple compartments. When you do inspection, when you do palpation, you do confirm all your inspective findings. In addition, you look at the margins and the border of the swelling, whether this swelling is mobile or not. It will help you to differentiate bony tumors from soft tissue tumors. Okay. You also should evaluate any scars and drain site of the previous surgery, because we know that if somebody has done an advent biopsy or an excision, these scars and drain site will harbor tumor cells, and you will have to excise them while taking the tumors out completely. And hence your surgery or your surgical plan may completely change, or it may become very complex and you might have to involve other specialties like plastic surgery, or sometimes limb salvage may not be possible at all. Few of the bone tumors and few soft tissue tumors also go to lymph nodes. So you must evaluate the regional lymph nodes as well. And last but not the least, we all know that we should evaluate distal neurovascular deficit, because limb salvage is essentially dependent upon that. So once you have all this information, you make a clinical call whether you can salvage this limb or not. And this is, in short, is all about the clinical evaluation of a swelling. Just one slide on hematological investigations. If we are talking about primary bone tumor per se, there are not many hematological investigations which can help you to clinch the diagnosis, except for a very few. Like, for example, in all lytic lesions, you must do alkaline phosphatase because a very high alkaline phosphatase can help you to differentiate giant cell tumors or aneurysmal bone cyst from Brown's tumor, which is the hyperparathyroidism. So this is one investigation which helps in primary bone tumors. Otherwise, most of these tumor markers help us to differentiate primary bone tumors from metastatic bone disease. So there are many tumor markers which happen specifically to the primary tumor. So, like for example, you will have raised PSA if a patient is a known case of CA prostate. CEA will be raised in GI malignancies. So this is how we differentiate them. METs and myeloma are again very important differential features, and hence we need to know that by doing hematological investigations in terms of serum electrophoresis, urinary Band-Jones proteins, you can actually diagnose myelomas by just doing these investigations, and you don't have to do further more investigations. So this is part about history and clinical examination. Now at the end of it, you will be having a clinical diagnosis, whether this is an aggressive or a malignant tumor, or this looks like a slow growing tumor which was there in one of the compartments, and whether it is from the soft tissue or the bone. So this sort of information you should be able to tell by this stage. Once you have this clinical diagnosis, based upon what is your clinical diagnosis, you will order specific imaging or specific radiological investigations. We have gamut of investigations as enumerated on the right upper corner of this slide, right from X-ray, as basic as X-ray, to as high as PET scan. Now, imaging helps you not only to give you a correct diagnosis, but it also helps you to tell the local extent of the disease. Now, because this is extremely essential, because this is what you need to know how you're going to treat this patient operatively or surgically. Distance spread is very important in malignant bone tumors because the kind of surgery you will do, the kind of magnitude of surgery or the planning or the reconstruction will depend upon whether this patient is going to survive or not. And with that will be dependent on whether this disease is located locally or it has spread distantly or not. Hence, imaging is a very, very essential component of evaluating any suspected tumor lesion. So as I said, based on your clinical examination, you will do local staging and distant workup. X-rays and MRIs are the best and the must investigations which are required to do local staging. And as I enumerated earlier, lungs are the most common sites. Hence, we do CT scan of the chest, and skeleton system itself is second most common site. Hence, we do bone scan, and these are specifically done in malignant bone tumors and not in benign tumors because the distance spread is extremely low in benign tumors. Now, a few salient points on how you should proceed or how you should do imaging. We must remember that the X-ray done must include the entire bone and it should be done in two perpendicular planes. As I told you that MRI is the best investigation for local evaluation of the tumor, and hence again like X-rays, the entire bone should be scanned and it should be in all necessary sequences. Why entire bone? Because these tumors can have skip lesions in the same bone, and if we do not scan the entire bone, we may miss some lesions and we may do inappropriate or incomplete treatment. For distance spread, as I said earlier, CT scan of the chest, you don't have to do contrast and you should do thin slices. For looking at the spread in the bone, we should do bone scan, and PET scan is new investigation, which we are evaluating further. And I will have a slide to tell you where exactly it is important. Now, let me open the slide completely. This is very important slide for all students. A lot of students come to me and they ask me to take a class only on this, how to read plain X-ray of a suspected tumor or a bone lesion. This is nutshell of a half an hour class. So you need to evaluate every suspected tumor lesion in 4 ways. Number one, categorize them into what type of lesion it is, whether it's a lytic lesion or a sclerotic or a mixed lesion. Point number two, you need to note what is the zone of transition. So what is zone of transition? Zone of transition is an area where normal bone meets abnormal bone. So if in this X-ray you see, this is the area. So if you can take a pen and you can actually draw a line as thin as that, and you can differentiate abnormal bone from normal bone, you know that this zone of transition is well defined or it's narrow. So what it signifies? So let's take example of some viral infection you have, not the coronavirus, some viral infection you have. When you get flu, your body's immunity is activated and you don't have to take active treatment most of the times, and then your body heals it over few days and you get rid of that flu. So this is body's immunity took care of that pathology or that insult which you had. Similarly, bone also react in the same way. If there is any lesion, if there is a disease in the bone, our immunity acts and try to restrict that disease into that space itself. Now here, the rate limiting factor is the speed at which this bone can stop the spread of the disease. Now, if the biology is slow growing, or in other words, if we are dealing with a benign tumor, then our immunity or our bone is good enough to restrict that disease into that specific area, and bone throws lot of bone into the surrounding area, and that becomes very prominent, and it is called as a narrow zone of transition, where it is completely clearly demarcated. The abnormal bone is demarcated from normal bone. So that is narrow zone of transition, which signifies is that you are dealing with a benign tumor, or in other words, you are dealing with a slow growing pathology. But if the disease is very aggressive, if tumor is growing very fast, it is not giving any time to the host bone to stop it, to restrict it. It will just spread all across the disease, and hence you will not see a narrow zone of transition, or the zone of transition will not be defined, or it will be wide. That signifies is an aggressive tumor or a fast growing tumor. So this is the concept of zone of transition. Third point is periosteal reaction. Please remember, periosteal reaction presence doesn't mean that you are dealing with a malignant bone tumor. Periosteal reaction can be benign and it can be malignant as well. Same philosophy works here also. If you have a slow growing disease, then there is a lot of bone thrown along the periosteum and it becomes thick buttress periosteal reaction all along the bone, and it is called as buttress periosteal reaction, which is typical of benign tumors, long standing disease, slow growing disease. But if you have a very aggressive tumor, then that doesn't happen, and you see various different kind of aggressive periosteal reactions. Like for example, you see hair on end in osteosarcomas, sunburst appearance in osteosarcomas, Codman triangles in osteosarcomas, and Ewing sarcomas, onion peel in Ewing sarcomas. So these are the examples of aggressive periosteal reaction. Fourth and very important is matrix. Now, matrix is something which tumor cells produce. Now, every tumor or every lesion produce something. Sometimes these matrix are radiolucent and sometimes they are radio opaque. So when they are radio opaque, you can appreciate the tumor matrix on X-rays. Typical examples are you see osteosclerosis in an osteosarcoma or in osteochondroma or in osteoma, that is benign tumor. Okay, so that is a sclerotic matrix or an osteoid matrix. So you have a whole category of tumor which will show osteoid matrix. Similarly, you can see chondroid matrix where there is a lot of cartilage produced. That will also be visible on X-rays by whorls and arcs formation. Again, typically seen in chondroid lesions like chondrosarcomas and chondromas. Okay, so that lineage will come into a different sort of category. Many tumors, they may have radiolucent matrix, like for example, giant cell tumors or aneurysmal bone cysts. We say that they don't have any matrix. Actually, they have matrix, but you cannot appreciate it because the tumor cells are producing a matrix which is radiolucent. Okay, like for example, fibrous dysplasias. They produce a lot of fibrous materials, which is somewhere in between bone and completely radiolucent. So you get a ground glass appearance. So this is how typically we evaluate. So mind you, tomorrow if you get a lesion, pick up that X-ray, try to categorize them into these four categories, and in about 85 to 90% of the time, you will be able to come to at least one or two differentials, and it will help you to diagnose these lesions better. Let's take one simple example. Let's, for example, you have a sclerotic lesion present in the metaphysis of a 17-year-old boy in the humerus, where you have wide zone of transition, aggressive Codman type of periosteal reaction, and osteoid matrix. It's automatically fit into osteosarcoma. On the other hand, if you have a lesion where you cannot appreciate any matrix, there is no periosteal reaction, it's in mature skeleton, it reaches the subchondral bone, we know we are dealing with giant cell tumor of bone. Okay, so it's simple, it's logical. Oncology is not difficult, but you need to use correct logic to understand in a systematic way. As mentioned twice earlier, MRI is the best investigation for local staging, and there are specific reasons. You can actually assess the disease extent within the bone and outside of the soft tissues very well with MRI. Relationship to neurovascular bundle and physis and joint is very well demarcated because this is what is essential for surgical resection. As I told earlier, that we may have skips in the same bone, which are again very well appreciated in MRI, not in X-rays or CT scans. Hence, MRI is the investigation of choice for local staging. This we have discussed earlier, that CT scan of the chest and bone scans are required for distant staging. I told you I'll speak about PET scan. It's a new investigation. Again, a lot of people love doing it for each and every case, but many a times it is an over expense and may not be required in every case. It is very essential to evaluate a patient of metastatic bone disease or secondaries of the bone from any other primary. Okay. In primary bone tumors, it has helped us to do adequate staging for Ewing sarcoma. Okay. I will tell you how it helps in Ewing sarcoma. In chondroid lesions, PET scan can help you to differentiate between low-grade chondroid lesions from aggressive or chondrosarcomas. Okay, so this is the main role of PET scan. Now, we have completed the imaging. We started with clinical diagnosis. We added up adequate imaging. So we reached a clinico-radiological consensus or a clinico-radiological diagnosis. Okay. So whatever you would have thought that, I was dealing with the aggressive lesion of the bone arising in the metaphysis in a young boy, looks like osteosarcoma or Ewing sarcoma. On the basis of that, you did adequate imaging in terms of X-ray and MRI, and you also did the skeletal survey by bone scan, and you also did the screening of the lung by doing CT scan of the chest, and you saw on X-rays, yes, my suspicion of osteosarcoma is confirmed. This looks like osteosarcoma. On the MRI, you saw, okay, fine, the local extent of the disease is 11 centimeters, neurovascular bundle is free. And on CT scan of the chest, you saw, okay, fine, it is clear, there are no metastases in the bone or in the lungs. But till now, you are only talking about hypothetical diagnosis. This is not confirmed. And how do you confirm it? You confirm it by taking a small tissue from that lesion, and that is done by doing a biopsy and proving it histopathologically, so that your clinico radiological diagnosis is confirmed by histopathology. And to enumerate the importance of this biopsy, let me show you this case. This actually is a 22-year-old gentleman who was seen by one of my classmates way back in a peripheral hospital. And he saw this lesion and he thought this typically fits into a giant cell tumor. And actually, if you ask me also, it fits. How? There is expansion of bone, there is no periosteal reaction, it's a mature skeleton, there is no matrix, there's no pathological fracture, there's hardly any soft tissue, the lesion is going right up to subchondral bone. This fits into giant cell tumor. So what he did, he went ahead and he did curettage of this lesion and he did bone grafting. But what went wrong? I think by now you must be learned that he did not complete imaging. He did not do MRI. Okay, so that he could not characterize the lesion further. In addition, he did not do biopsy and he just did surgery directly, and he sent this specimen to Tata Memorial Hospital, and you will see that this was a high grade sarcoma of the bone. So what exactly it means, that how typically, irrespective how typical the imaging looks, if you are planning to start on any kind of treatment, whether surgical, whether radiotherapy or chemotherapy, you must have a histopathological diagnosis. It is must. In the era of medical legal issues, again, it becomes more important because this one case can actually finish your career. So we must do biopsies. But again, it is very important that biopsies must be done by trained surgeons. And this article, which was way back published by Professor Mankin from United States, and he talked about that there are so many diagnostic error, wound problems, treatment change, unnecessary amputations, and adverse patient outcomes happens because of doing wrong biopsies. And they clearly stated that all these complications are 3 to 5% more when the biopsy is done by non-trained people in non-sarcoma centers. And hence, if you get such patients, you should refer these patients to people who are treating sarcomas regularly, or at least how we modify this in our situation or in our country is that to the people who are trained in doing biopsies or who understand the concept of limb salvage. So this is again very important. So biopsy actually is a whole class in itself, and it requires a lot of time. But just for the time's sake, I would like to say that nowadays we do needle biopsies. It is very easy to do. It can be done in OPD under local anesthesia, practically no infection, very less tissue contamination. You can use guidance by ultrasound or CT guide biopsy to reach various cores or various areas of the tumor. And the representation tissue and diagnostic accuracy is also very high. And thus, we prefer needle biopsy over open biopsy, which has various disadvantages. And this is all what you need to do a needle biopsy. This is Jamshidi needle, local anesthesia, and a single stitch. And this is a few pictures of how to do biopsy after uh, all aseptic precaution, draping and cleaning and draping. You mark the site and you give local anesthesia. You give a small stab incision. You put the needle with rotatory movements, and then you take out the tissue by tilting the needle, and then just do a small stitch, and you see that how nicely it is done, and it just need a small single stitch. Okay, so this is how this biopsy is done. Again, very important slide to enumerate that biopsy is not the first investigation you do. You actually evaluate this patient in the way I told you till now. You need to take a proper history. Unless until you have a proper history, you will not know how to examine this patient. When you do appropriate clinical examination, you have a clinical diagnosis. Based upon that clinical diagnosis, you will advise or you will order specific imaging investigations. Because let's, for example, you on clinical examination, you suspect a benign tumor. So the set of investigations which you will ask will be completely different from the set of investigations which you will ask for a metastatic bone disease or secondaries in the bone or a malignant bone tumor. Okay, so this has to be systematically approached. And once you know the imaging, then actually biopsy is planned in a way that it comes on the scar of the final surgery. So when I am asking my fellows to do biopsy, the final surgical procedure is actually in my mind, and I cannot plan all that unless until I have adequate imaging, which will be in terms of MRI and full evaluation is done. So this is the importance of following this correct sequence. So as we stated that our diagnosis stands on these three pillars and all need to match each other to clear the picture and diagnosis completely. Otherwise, we have to reconsider it and revisit the diagnosis. So once we have the third pillar also standing, we reach a correct diagnosis and then we move further. The next part of this presentation talks about staging. Now, what is staging? Staging is to look at the distant spread of the disease. I have been talking I've been talking in my slides that we need to do a CT scan of the chest, we need to do a bone scan to know the distant spread of the disease. So how it impacts, how it affects, I'll show you now. What you need to understand, as I enumerated, the set of investigation which you ask for a benign tumor is different from malignant is the example here. So while staging a giant cell tumor, you just need to do local X-ray and MRI and a plain chest X-ray. That is good enough because we know that the rate of distance spread of benign tumors is extremely less. You will only do a bone scan where it is here it is written optional. You will only do when patient has bony symptoms or you are suspecting a multicentric giant cell tumors. Otherwise, you do not do that. Okay. Once we now second example is to look at Ewing sarcoma. Now, Ewing sarcoma staging is a bit complex. You do same kind of local staging, that is MRI and X-ray. In addition to that, you have PET scan available with us nowadays. If PET scan is not available, you have to do bone marrow biopsies from two different sites. So the advantage of PET scan in evaluating or staging bone Ewing sarcoma is that we can obviate the need of invasive procedure like bone marrow biopsies. And especially these tumor occur in children, you might require GA to do bone marrow biopsies, and hence if you have PET scan, it is good enough. When we talk about osteosarcoma, they are staged with a CT scan of the chest and a bone scan, and we don't need bone marrow biopsies. In osteosarcoma also, we have few intermediate or low grade. There, we do not need distance staging, and they are staged like benign tumors. So this is in nutshell about staging. Now, this staging investigations, when we stage these patients into some different staging systems, which help us and tell us what sort of treatment to offer. Okay. Now let's see few staging systems. This can come as a short note as well, and it may be asked in your Viva. First and the easiest system is MSTS or Annie King staging system. Annie King gave a simple staging for benign tumors, which I enumerated earlier, that is latent, active, and aggressive. And for malignant bone tumors, what he did, simple staging, all low grades in stage 1, all high grades in stage 2, and any kind of metastasis, whether nodal metastasis, whether lung metastasis, whether bony metastasis, went to stage 3. Okay. Now within stage 1 and 2, if it's a small tumor that is within the compartment, that is within the bone, it becomes stage A. Extracompartmental becomes stage B. So similarly, we have low grade intracompartmental 1A, low grade extracompartmental 1B, high grade within the bone, that is intracompartmental 2A, extracompartmental 2B. Okay, so simple, easy to learn. But there were a lot of fallacies in this, because you cannot group all kind of metastases in one way, and hence a more elaborate and AJCC staging system came into picture, which looks at the primary lesion, what is the aggressiveness of the lesion, which looks at spread to the regional lymph nodes, because only lymph node metastasis behave differently from others, and then metastasis to other site. Okay, now when we look at this, so tumor, that is the primary tumor, was categorized into three, that is T1 lesions, as you can see here, less than 8 centimeters. Okay, T2 tumors, which are more than 8 centimeters, or you can have T3 tumors, which have skip lesions in the same bone with a normal intervening marrow in between. Okay, so this is skip, which are categorized as T3 lesions. Fine. So, and if you have any nodal metastasis, it becomes N1. When they are looking at distant metastasis, they categorize. If you have only in the lung, you become M1A. And if you have any other site like other bones, you become M1B. Why this categorization is important is because any kind of staging, you must have talked about fecal and early staging and other kind of staging. Staging tells you the prognosis. Staging guides you what to treat, and hence we know that the outcome of the patient who have only solitary lung metastasis is completely different from patient who has bone and lung. Okay, so you do different kind of treatment, and hence this is important. And then we get this grouping, and then we can divide them into stage 1, 2, 3, or 4. Okay, now again the same thing, that why we do this staging. Now staging tells us two very important questions which every patient will ask us. Doctor, what sort of treatment are you going to offer me? So it guides us that what is the appropriate treatment at a particular stage of the disease. And second is, doctor, whether I will be fine or not, whether I will survive or not. So what is the prognosis of that patient once you do the appropriate treatment? And hence staging is very important. Few more salient points. I think this is my second last slide. Tumors are not just surgeon's disease, or you cannot treat these tumors alone. You need a team with you. You need to build up a team, not just for the treatment, but actually for the diagnosis also. And hence the concept of multidisciplinary approach or multidisciplinary team is very important when we are dealing with tumors. And there are a lot of guidelines which talks about this. If you need a correct diagnosis, you need a correct radiological interpretation, you need a good radiologist. You need a good histopathologist who can diagnose it correctly, because your treatment will be based on what kind of disease, whether it's malignant or benign, in benign, whether it's aggressive or active. Okay. And then obviously, if you are dealing with malignant bone tumors, you require help of medical oncologists, radiation oncologists, trained occupational physiotherapists. So you need entire team to help you to complete the treatment in the right way. And hence, multidisciplinary team concept is extremely important in the management of benign tumors. So I think I'll stop here, and thank you so much once again for having me here and giving me opportunity to share few of my thoughts on how we can evaluate bone tumors in a good way and proper way. I've tried to simplify it in a as simplified manner as possible, and I'm happy to take if there are any questions.